Good afternoon and welcome to our series of webinars focused on bringing you information about COVID-19 related topics. The information in these weekly webinars is geared toward long-term care and skilled nursing facilities, but we encourage everyone who is interested to attend. Today's presentation is a deep dive into adverse drug events, learning through cases and best practice. My name is Kathy Caudill. I'm a communications specialist at Quality Insights. Before I introduce today's speaker, Dr. Storm, I'm going to run us through some housekeeping items. Everyone has entered today's meeting on mute, but we will have time for questions at the end of the presentation. If you have questions, please submit them using the chat or the Q&A tool. And as I said a moment ago, this webinar series is usually geared toward long-term care, but today's webinar is a special presentation for all provider types. So for those of you who work in long-term care, we invite you to join us every Wednesday for more webinars in this series. And next week, we'll be discussing enhanced barrier precautions. This webinar is eligible for continuing education credits for nursing. Here you can see the details about those credits. And to obtain the credits, you must watch the whole 60-minute webinar, as well as complete an evaluation and reflective questions following the webinar. We will share a link for the evaluation after the presentation, so if you're interested in obtaining the CE credits shown here, please stick around to the very, very end for that link and further instructions. Can you go to the next slide? Thank you. And now I'd like to introduce our guest today, Dr. Storm. Dr. Storm is Medical Director here at Quality Insights. She has a background in nursing home care, internal medicine, and healthcare leadership. Most recently, she served as Associate Medical Director for Optum United Healthcare. She has also served as Regional Medical Director for 38 long-term care facilities in West Virginia. She earned her DO from Lake Erie College of Osteopathic Medicine and completed her postgraduate training at Mill Creek Community Hospital in Erie, Pennsylvania. Dr. Storm, thank you for joining us today, and you can take it away.
Thank you, Kathy, and thank you everybody for joining us. This is going to be an action-packed full presentation. So there's a lot of slides. I just want to tell everyone that we may not go into detail in every single slide because there's so much material, but the slides will be available to you for resource after the presentation, and feel free to reach out to me via email if you have any questions. My email will be available after the presentation. So we'll talk about our learning objectives. We're going to talk about the definition of adverse drug events, and you're going to be able to recognize the different ways that they present themselves in the clinical setting. We're going to talk about the drug classes that cause ADEs. That's how we're going to say adverse drug events. We're going to say ADEs. We're going to understand which individuals are at greatest risk. We're going to talk about areas for improvement in different healthcare settings to prevent ADEs or ameliorate them. We're going to be talking about being able to recognize different types of ADEs and understand when action needs to be taken. We're also going to be talking about different databases that are available to obtain data from the general public, from providers about adverse drug events. So then that data can be available for other resources to warn other members of the public, other providers, etc. We're going to talk about the ways that hospitals have been successful in reducing their ADEs. We're going to talk about prevention strategies to prevent ADEs in the nursing home setting. This has been a really challenging environment for ADEs. We're going to talk about potential signs that may manifest themselves in nursing home residents that could be due to adverse drug events. And then we're going to close out talking about cognitive bias, something that probably a lot of us don't think about when we are thinking about adverse drug events, and how these cognitive biases can play a role in adverse drug events. We're also going to talk about how adverse drug events can manifest themselves in certain ethnic groups. I really love this quote by Dr. Bernard Lone. He was a cardiologist, and he pioneered the idea of letting patients actually sit up in a chair after they had a heart attack. At the time, most patients were just told to lay in bed for 4 to 6 weeks. So he pioneered the idea of getting people up and getting them just to sit up, and it actually improved outcomes. He also was a co-inventor of the direct current defibrillator. And he said, do as much as possible for the patient and as little as possible to the patient. So we want to help the patient, but we don't want to hurt them. And sometimes we know that those two things overlap in medicine. So what is the definition of ADE? We have multiple definitions, though they are somewhat similar. CMS, the definition is an untoward, undesirable, and unusually unanticipated event that causes death, serious injury, harm, or risk thereof. The CDC is just simple when someone is harmed by a medication, and this happens a lot, right? The FDA definition is any untoward medical occurrence associated with the use of a drug in humans, whether or not considered drug related. I really love that definition because I will say, oftentimes in medicine, we have something that happens that we might not associate with a medication, and then we might layer another medication on top of it to treat the adverse drug event. And then we have a bigger problem. So it's really important that we recognize that when something occurs to a patient that is adverse, an adverse event, that we consider drugs first. So numbers, how big of a problem are ADEs? In the outpatient setting, it seems like it's not incredibly high. 4 emergency visits per 1,000 individuals, 2013 to 2014. But what's striking is that over a quarter of these individuals had to be admitted for these adverse drug events. So substantial. We look in the hospital, it's somewhat difficult to obtain these numbers, but in 2019, they did a study and there were 70 to 139 adverse drug events per 1,000 discharges. So another fairly significant number. We look at nursing homes. Nursing homes have the most difficulty with adverse drug events. There was an OIG report released in 2014 that looked at individuals who were admitted to the nursing homes, and they looked at their first 35 days of their stay. Almost a quarter experienced an adverse drug event. 11% of these adverse drug events caused temporary harm. And this is going to be the most striking number. Almost 60% were preventable that the OIG found. So somewhat alarming, but we have multiple opportunities for improvement in the nursing home for these numbers. So when we look at medication use in the US, you can see, I just wanted to put this up to demonstrate that if you look at these high areas in green, it's individuals who are mostly over 60. So we know that the individuals over 60 are taking the most medications in the United States. And this I just put up, I thought this was interesting. If you look at individuals 60 years and over, you can look at the most medications that they're taking. And, when we look at these, we can kind of figure out that these might be the medications that could be causing problems. Anti-diabetic medications, beta blocker, blood pressure medications, and lipid lowering drugs. So this is what older people are taking. But if you look at these other classes, you can see what other age classes are taking medication-wise. So what are our biggest offenders? What are our biggest drug classes that are causing the most adverse drug events? Anticoagulants, a big problem. When you're bleeding, it's a big problem. So our direct oral anticoagulants, aspirin is also an anticoagulant, warfarin anticoagulant. Our diabetic medications, insulin causes a lot of problems, right? It is essential with our diabetics, but we have to manage it properly because we have hypoglycemic episodes. Antihypertensives, heart medications can cause adverse drug events. Opioids, huge problem. So overdose, obviously, but we also have non-fatal issues. We may have things happen with individuals taking opioids that we might not anticipate. That's why we have to do a lot of education around opioid prescribing. And we have to think about what other medications are individuals taking in combination with their opioids, because opioids do not mix well with a lot of medications. And I put tramadol up here because sometimes people think, oh, it's not an opioid. It most certainly is an opioid, and it needs to be included in this class. Antipsychotics, huge problem in the nursing home. Benzodiazepines, when benzodiazepines are combined with opioids, that's a bigger preponderance of adverse drug events. And then antibiotics. We don't think about antibiotics, but antibiotics are a huge issue with adverse drug events. So our types of ADEs, they're broken down into different types. We have medication errors. So this is any error at any point along the pathway that begins when the provider orders the medication to when the patient receives the medication. So you can think about what can happen along that pathway. Something can get written wrong. The wrong medication can be put in the bottle at the pharmacy. So any error that happens along that pathway. We have preventable ADEs, and that's obvious. That's an adverse drug event that causes harm, and it's due to medical error, and it could have been prevented. Potential ADEs. So these are adverse drug events that were prevented. Perhaps there was a medical error or something was caught before the individual experienced an adverse drug event, but it could have happened. So these are wonderful learning opportunities. If we have a potential ADE that we catch, this is a wonderful time to say, you know what, we really need to look at our process and determine if we need to fix our process. Ameliorable ADEs. So these are about adverse drug events when the individual perhaps had to have the medication, could not have been prevented, but perhaps something could have been done to mitigate the effects. So perhaps a dose could have been reduced. Perhaps a different medication in the same class could have been trialed. Perhaps the patient could have been told to take the medication in the morning. Say if they're taking a diuretic, perhaps they could have been told to take the medication in the morning instead of at night, because we know that you have to go to the bathroom a lot when you take a diuretic. So perhaps you tell the patient, go ahead and take it in the morning, so then you're not woken up all night long going to the bathroom. Non-preventable, obviously that means we could not avoid harm. We didn't know it could have happened, and it happened, but it was not avoidable. So we have some difficulty in determining adverse drug event numbers because possibly due to infrequent physician contact. Most people are not in contact with their physician every day on a daily basis, telling them what's going on. So that could lead to difficulty in determining numbers. Patients may not recognize a symptom as an adverse drug event. Something could be going on for a long period of time. Maybe they have a rash on their back. They didn't think of it as due to them recently taking a new blood pressure pill. So patients may not be able to communicate symptoms to describe adverse drug events. And this is very common in our nursing home patients who have dementia or other diagnoses. So they may not be able to tell us that they're having a severe headache due to a blood pressure medication or an opioid. Patient may stop the med.
Okay, I'm going to jump in here a moment because I have it confirmed that I'm not the only one who Jean has frozen for. Okay, here we go. It looks like Dr. Storm got connected back in. You're on mute, but it's good to see you back.
Oh my goodness.
So where you left off, you were on number 5 of that slide with the list. So let's get your screen shared again.
Okay, I'm going to get back there. Okay.
All right. Yep. So I think we're on number 5 of that previous slide. Okay.
So individuals at risk, individuals taking multiple medications, which is called polypharmacy, individuals who are older age, individuals with chronic disease, and individuals taking supplements. So it's really important to make sure that physicians know about every single medication that a patient is taking. And we have to ask patients, are you taking any other medications besides the ones that we know we're prescribing you? So this was an interesting study that was done in the outpatient setting, and it was an 11-year study, which is kind of unprecedented. So they looked at potential adverse drug events in a number of physician practices. So it was done in 1995 to 2005 using the National Ambulatory Medical Care Survey and National Hospital Ambulatory Medical Care Survey results. So during the period of study of this 10 years, the adverse drug events actually increased from 9.1 to 16.9 per 1,000 persons. So increased fairly significantly. And antibiotics were the most frequently causative agent of adverse drug events. And I will say, I don't think this is because antibiotics are the most problematic of the frequent flyers and adverse drug events. I will just say it's because a lot of antibiotics are prescribed, probably more than any other medication. So individuals at risk they found was increasing patient age, polypharmacy. So these were individuals who were more likely to experience adverse drug events according to the study. And during the study period from 1995 to 2005, the number of patients taking 5 or more medication doubled. So in 10 years, they had people who were taking 5 or more medications. That group of patients more than doubled, which is fairly ridiculous. It's a lot of medications. So antibiotic prescriptions, if you look at this map, as we get into the darker colors, we have more antibiotic prescriptions per state. So you can kind of pick out what states you're in. If you're darker, that means the more antibiotics are being prescribed. So this is 2021, so fairly recent. So we're prescribing a lot of antibiotics. Unfortunately, opioid prescriptions have gone down in that time period. So that may be due to the recent guideline. I think providers are being more thoughtful about opioid prescribing, but opioid prescribing did go down in that time frame. So we're just going to talk about some patient cases, and these are based in the outpatient setting. This is a 75-year-old male. He called into his physician's office with a complaint of burning and pain with urination. He had no fever, chills, no blood in his urine. The physician sent a prescription for a course of ciprofloxacin, which is an antibiotic, to the patient's pharmacy, even though ciprofloxacin was listed as an allergy. And the patient went to the emergency department 2 days later with a rash. So this is definitively a medical error and a preventable adverse drug event. And these things happen. This is why we have to check and double check. Patient case number 2, this is a 28-year-old female. She sustained a fall and was diagnosed with an ankle fracture. While waiting an appointment with an orthopedic surgeon, she saw her primary care doctor who prescribed oxycodone for pain. The next day, she sustained a motor vehicle accident after she took the medication and became dizzy and confused while driving to pick up her son at school. What type of ADE occurred? So this may have been an ameliorable adverse drug event if this individual had gotten counseling at her primary care office to say, do not drive when you take this medication, because it may cause you to become dizzy, may cause you to become confused. You should not operate a car. So that is what would make this a ameliorable or preventable adverse drug event, is if we did some counseling with the patient. A 78-year-old female presented to her PCP's office in follow-up after being seen in the emergency department for a DVT of her right lower leg. She was discharged with a prescription for apixaban, which is an anticoagulant. Her physician counseled her on the medication and provided additional refills. 1 week later, she presented to the emergency department with rectal bleeding, and she was admitted to the hospital with a diagnosis of GI bleed. So in this case, this is not preventable. This patient needed to be anticoagulated due to a clot, and some patients do develop GI bleeding. So this is not something that's preventable. Example 4, 42-year-old male was diagnosed with diabetes type 2 several years ago. His blood sugar remains uncontrolled on oral medications, so his physician decides to start insulin. 2 weeks later, the patient came to the emergency room with a blood glucose of 32 because he started a crash diet, and he continued to take his insulin as prescribed. So in this case, perhaps this is ameliorable with education. You have to tell patients, please, if you decide to change your diet drastically, call us, let us know, so we can adjust your insulin accordingly so you don't end up in the emergency room with hypoglycemia. So counseling in this case would have been needed. And the last patient example, 82-year-old male was recently discharged from a stay at a skilled nursing facility with a hip fracture. He is taking hydrocodone for pain. He presents to his primary care provider for follow-up and complains of continued hip pain and constipation. The primary care provider sends a refill for his hydrocodone, which is an opioid, to the pharmacy. The patient presents to the emergency room 5 days later with nausea and vomiting. He's found to have a fecal impaction. So this is preventable because we know when we prescribe opioids, they're appropriate in this case. This patient has a hip fracture. We have to make sure that we also prescribe medications to prevent constipation. So if we had done that, then perhaps this gentleman would not have ended up in the emergency room. So opportunities for prevention and improvement. Increased provider education. So we as providers understand that anything that is happening could be potential adverse drug event. Increase provider communication to patient. So we're making sure we're providing really good education to our patients when we prescribe medications. Increase just patient education, so patients understand when a potential ADE could be happening. Checklists. I love checklists. Checklists have been shown to work in healthcare. This is a checklist that was used in a study to discover potential adverse drug events in home care patients. And, when you have a patient that has a new symptom, you can just check it off and potentially it's an adverse drug event. So checklists can be put together fairly easily or found online. This is from JAMDA and is available in the PowerPoint. So I just wanted to talk a little bit about reporting. I'm not sure everybody is aware, but the FDA has a safety information and adverse reporting system, MedWatch. So MedWatch receives reports from the public. So the public can actually submit FDA regulated. This public can just provide their own report into this database, and I'll show you the link and how that's done. And that is the link. And then the FAERS FDA adverse event reporting system actually collects all this data from MedWatch and puts it into a searchable database, which is really fun. I will say I've kind of played around with it a little bit in searching. So this is MedWatch. And as you can see, health professionals can begin an online report, or consumers or patients can begin a report. You can save an incomplete report and go back to it later. This is what the dashboard looks like. I know it looks a little bit busy, but when you can just go into this FDA adverse event reporting system and you can actually search. And you can see here, I searched escitalopram, and you can actually search multiple medications if you ever are thinking, oh, maybe I'm experiencing an adverse drug event, and it will tell you what the most common adverse drug events are for the medication you're searching for. So it's really, really interesting, and it really gives me, it makes me feel good that this is being collected for medications. So some important points about FAERS. Information in the reports is not validated. So it's not like the FDA is going into all of these reports and saying, yes, this is actually accurate, this is not accurate, this is true, this is not true. So to go in and say, oh, look, someone had this event, it's not a validated database. And existence of any report doesn't indicate causation. So we have to keep this in mind. Just because you have a report of someone getting a rash from this medication doesn't definitively mean that the rash was caused by the drug. That just means that there's a potential link. Rates of occurrence cannot be established by the reports, and there are duplicate and incomplete reports in the system, but it's a helpful system in gathering data. So let's talk a little bit about hospital settings, because hospital settings have been doing a good job in reducing adverse drug events. But this slide just shows what the most common cause of adverse drug events are in US hospitals. And as you can see, steroids are number 1, antibiotics number 2, and opioids are number 3. So I was surprised to see steroids on the list, but our other 2 favorites are up there, are antibiotics and our opioids. So Partnership for Patients was implemented in 2011 by CMS to reduce preventable hospital acquired conditions, including ADEs. So these are possibly preventable things that happen in the hospital that we don't want to happen. And ADEs are among these preventable hospital-acquired conditions. Hospital engagement networks provided education and assistance to reduce preventable patient harm. And it was successful in reducing patient harm in 30-day readmissions. And you can see adverse drug events are in this table. And so adverse drug events were reduced. So really rigorous education and feedback from third parties, which is kind of what we're doing here, can really make a difference. So this really gave me hope. So it was a successful strategy. So opportunities for continued improvement in the hospital. Care transitions, we all know it's very challenging to have a patient go from the hospital to the nursing home or the hospital to home health. So care transitions can always be better, especially when new medications are being prescribed. Improved education for patients and families at discharge, improved communication with patients and families, period. And then improved communications with the primary care physician. I think this is always a challenge. If the primary care physician is not taking care of the patient in the hospital, it's really good to have the physician in the hospital talk to the primary care physician directly about what's going on. So a few patient case examples. A 55-year-old male presents to the emergency department with shortness of breath, dyspnea, and is diagnosed with atrial fibrillation. He started on a heparin drip in the ER after initial CBC, PT, PTT are done. So these are blood tests associated with blood thinning when we want to start somebody on a heparin drip due to atrial fibrillation or a clot. So he's admitted to the medical floor, and repeat labs are not done until 24 hours later when he develops blood in his urine. His PTT is found to be greater than 200. So this is based on a case I was involved in the hospital. So things happen. This was a medical error. And sometimes we have something that is started and perhaps orders get missed or patient's labs can't be done. And in this case, labs needed to be done at a very specific time period. So every 2 hours or every 4 hours, depending on what the lab work showed. And in this case, they were not. So this patient was put at risk for bleeding. And I'm sure this happens all the time in hospitals across the country. Mistakes happen. But in this case, this was a medical error and it was a preventable adverse drug event. Fortunately, no harm the hematuria of the blood in the urine stopped when this issue was resolved. So the patient was not permanently hurt in any way. An 82-year-old female presents to the emergency room after falling at home. She is diagnosed with a right femur fracture and admitted for surgical repair. After the surgery, she is ordered oxycodone 10 milligrams every 4 hours as needed for pain. On post-op day 2, she complains of abdominal pain, bloating, and nausea. abdominal x-ray is done and reveals ileus. So our bowel is slowing down. We've put a patient on an opioid. And again, we forgot to start a bowel regimen to prevent constipation or other effects on the bowel. So this is a preventable because we didn't give any medication for opioid-induced constipation. And perhaps maybe it would have happened if we given something, but perhaps it would have been ameliorable. So we always need to make sure that if we do prescribe an opioid, it's done appropriately. Patient example number 3, a 74-year-old male presents to the emergency department from the nursing home where he resides with fever and tachycardia. He is admitted to the hospital with a diagnosis of sepsis. The day after his admission, he becomes agitated and refuses oral medications. He's given haloperidol, which is an antipsychotic, and lorazepam, which is a benzodiazepine, intramuscular for agitation. 2 hours after the medication is administered, he falls and sustains a fracture of the left femur. So in this case, maybe somebody would say this is not preventable. This patient was agitated and he needed to be sedated. So it is very difficult. If this patient is not a danger to himself or others and he's just agitated and refusing oral medications, then there's really no indication to give this individual an antipsychotic and a benzodiazepine. There just needs to be really good care. If a patient has delirium, which is very common in a patient that comes from the nursing home, there just needs to be appropriate care for delirium, not medications. Medications are really, down the line when we have delirium. So I would say that this is preventable. Patient example number 4, a 42-year-old female is admitted to the hospital due to abdominal pain from appendicitis. After her surgery, she is ordered oxycodone 10 milligrams every 4 hours is needed for pain. She's discharged with a prescription for 90 oxycodone 10 milligram pills. It's a lot of oxycodone. She does not take any of the oxycodone after her discharge, and she just puts them in her medicine cabinet. This happens a lot. Her 14-year-old son finds the prescriptions 2 months later. He overdoses on the oxycodone and he's not able to be resuscitated. So preventable versus not preventable. I would say this is preventable. There's no reason that she should have been prescribed 90 oxycodone. That is a lot of oxycodone. So there's no reason that she should have been prescribed that amount. So I would say this was definitively preventable. Also, we really need to counsel patients when we are discharging them from the hospital with opioids for safe disposal. If they are not using that medication, it needs to be disposed of. It not only can other individuals in the house overdose, but your house could be broken into. It's not safe to keep opioids in your house if you're not utilizing them. So we're going to move on to nursing homes, and I'm going to talk about that Officer of Inspector General report, which looked at adverse events in skilled nursing facilities. As we said, 22% of Medicare residents experience an adverse event during their SNF stay. 37% of these adverse events were due to medications. I thought this was interesting that 4% of residents experienced at least one cascade event, which is a series of multiple related events. So that means perhaps the resident has an issue with a medication, which causes another issue, and then another medication is started, and then maybe we have another adverse event from the combination of the medications, and so on. And we go on and on and on and on. This happens a lot in nursing homes, and we really have to be careful. We really have to think that anything that is adverse happening to a nursing home resident is medication first. And again, as I said, almost 60% of the adverse events were determined to be preventable. So this is the adverse events identified among Medicare skilled nursing facility residents by category. And you can look that events related to medications was 37%. So fairly high. And then you can look at the other events. We all know of these: falls, excessive bleeding, pre-existing medical conditions, acute kidney injury. Then we have infections, urinary tract infections, C. diff. So medications are the big ones and usually preventable. So why are adverse drug events such a big problem in the SNF? We have infrequent physician visits. We often have a physician that will see a patient when they first are admitted to the facility, and then they might not see the patient for 30 days after that. So the physician might not be there to recognize that an ADE is occurring. We have staff turnover that occurs, and especially now in our nursing homes, we're seeing a great deal of staff turnover. So when we have staff that are very familiar with our patients, they recognize when an adverse drug event is occurring, and then they can sound the alarm when something is new and something isn't right. So when we have increased staff over, then we have increased adverse drug events. We also have very medically complex patients in the nursing homes. We all know this. So we have patients that are taking many, many medications. I've seen patients that are taking 30 to 40 medications, which is a lot. And there's got to be one medication that's causing an adverse drug event on that list. And there's limited support. We all know that there's limited support to get lab studies, limited support to get imaging. We also have limited pharmacist input. So we might have a clinical pharmacist that reviews a patient's medication regimen maybe once a month, and perhaps they aren't doing that, in between. So all of these things add up to make adverse drug events big problems in nursing homes. So when we talk about geriatric syndromes, it's a term used to describe a group of common health conditions in older people that really don't fit into disease categories. So we're talking about frailty, we're talking about functional limitations, we're talking about falls, depression, polypharmacy, malnutrition. So when we think about the geriatric syndromes, they arise from, the age-related interplay, chronic disease, functional stressors in older adults, and each interacts with the other. So when we think about geriatric syndromes, we have cognitive impairment, delirium, depression, as I mentioned, falls, frailty, and incontinence. And when I think about these syndromes, I can say that adverse drug events, a medication could cause any of these symptoms. So these are really common in the elderly. These are really common in our nursing home patients. And I think we have to be thinking about, could these things that are going on be due to a medication? So potential adverse drug event warning signs in our nursing home population. Weight loss is huge. So I know you all get triggered when a weight loss happens, and I think probably we get a dietary consult or we add a supplement. We should be looking at medications first and foremost when we have a weight loss. An ADL decline. So the patient was previously propelling themselves in a wheelchair and now they are bedbound. That is also something that could be due to medication. We have mental status change. Patient was able to get down to the dining room, know when breakfast is occurring, but now they have no idea. They don't know the time of day. We have an abrupt change. We think about medications. The resident is complaining. Got to look at medications. I know it's very challenging in this in the time that we're in to really listen to residents with what they're saying, but the resident might be telling us that they're having an adverse drug event. Physical signs, rashes, the most obvious one if we think about, allergic reactions. Falls, medications. Anytime I think about an individual as having falls, and I love to talk about falls cases, I think they're the most challenging. I pull up the patient's medication list, because falls can happen from our usual suspects like opioids and benzodiazepines and antipsychotics, but falls can also happen from antiarrhythmics. They can happen from a wide variety of medications. And I have actually stopped. I had one patient, I stopped digoxin in this patient, and nothing happened to the heart rhythm. The heart rhythm just was the same after we stopped the digoxin, which is antiarrhythmic. But falls were essentially went from 2 or 3 falls a day to none. So you really have to think about every medication a patient is receiving and what symptoms, and perhaps some of the symptoms that they are experiencing could be due to the medication. Constipation. We talked about opioid-induced constipation, a huge problem. Urinary retention, again, also from opioids. Opioids caused urinary retention. So you have a patient who is not urinating, you think about opioids. Sudden change in labs. So we start a patient on an ACE inhibitor for high blood pressure, and all of a sudden their renal function deteriorates markedly. So we need to think about a medication. So our drug offenders in the nursing homes, antipsychotics are really, really huge. And I think we probably could do a whole webinar on antipsychotics, especially CMS is talking about really looking at the appropriate diagnoses for use of our antipsychotics. And especially because antipsychotics do cause adverse drug events. Opioids, huge, as we've been talking about. We talked about constipation, we talked about urinary retention, we talked about mental status changes, we talked about falls, dizziness, all of these things. Warfarin and other anticoagulants, including aspirin, which cause bleeding. Insulin, we really have to be careful. We have our nursing home residents, sometimes they do not eat well suddenly. So we really have to be cognizant and make sure that we are being aware. So we're not giving residents insulin when they're not eating. Gabapentin, again, I probably could do another webinar on gabapentin. Gabapentin orders have gone through the roof recently in nursing homes. And interestingly, a lot of physicians are saying that gabapentin could be causing a lot of problems and adverse drug events in nursing homes, and providers may not be aware of the problems they're causing. And I think gabapentin probably is being ordered more because opioids perhaps are being prescribed less. So it might be, well, we can't use an opioid, so let's try gabapentin. But gabapentin carries risk in this patient population. And tramadol. Tramadol is not without its difficulties. It is a very unusual medication. A lot of people will go to it instead of utilizing an opioid, but it is an opioid-like medication. I treat it like an opioid, but it's interesting in the way it's processed in the liver. It has effects on serotonin, so it can affect people's mood fairly significantly. So we have to be really careful. I've seen patients have significant mental status change with tramadol, that the mental status changes resolves when I stop the tramadol. So again, we always need to think about medications when we have a change in a patient. Benzodiazepines, we all know the difficulty benzodiazepines can cause, and dizziness, mental status change. Antibiotics, we have C. diff, we have rashes. Digoxin, I talked a little bit about. Anticholinergics in our nursing home patients, we always have to worry about anticholinergics when we're thinking about falls. Proton pump inhibitors, something that we're really not thinking about, but proton pump inhibitors have been linked to kidney issues. They've been linked with increased risk of pneumonia. They've been linked to increased risk of C. diff. So proton pump inhibitors are not benign. And I will say, I think they're causing a lot of problems in nursing home residents, and perhaps they're not needed. Sometimes the patient arrives from the hospital on a proton pump inhibitor and it's not needed. And NSAIDs, huge problem with kidney issues and GI bleeds. And metoclopramide, a medication that is on the Beers list that really shouldn't be used in the nursing home population. So our ADE prevention opportunities, care transitions, as I said, care plan meetings. Let's look at medication lists at every care plan meeting. Physician visits, medication reconciliation. Physicians should be looking at every single medication at every single visit. Our antibiotic stewardship plan, we should be questioning, does a patient really need an antibiotic? Our QAPI meetings, that's what we should be doing, is looking at medications. Our pharmacy recommendations, we should be utilizing our pharmacists to get on board with an ADE prevention strategy. Say, listen, we're looking for adverse drug events, please help us. Outside consultant visits. I've had patients go to neurologists and they've made suggestions to stop medications, and I really appreciate it. And then the Beers list, which is a list of medications that is potentially inappropriate in older adults. So we should always be consulting this list if we think that we're going to be prescribing a medication that's not appropriate for an older patient. I'm going to talk about some cases. This is a very difficult case for me, again, based on a case that I was involved in many, many years ago. 57-year-old female presents to the hospital for an elective lithotripsy. She had kidney stones, so she was having those worked on with sound waves. She became confused after the procedure, and she was diagnosed with a stroke. So this is a sad case, patient who was actually living at home independently prior to the procedure. So nursing reports in the hospital that she's agitated at times, and she came into the nursing home for rehab. She's taking atorvastatin, aspirin, Levemir. She's taking olanzapine, antipsychotic, and a lot of Depakote. Her diet was dysphagia advanced, and she was prescribed honey-thickened liquids. She had difficulty swallowing, apparently. She had frequent falls, and the nursing reports in the nursing home that she's restless, confused, she won't participate with therapy, and she's unable to communicate. Her labs are finally done a week after admission, and as you can see here, her sodium is 164. She's profoundly hypernatremic, and an attempt is made to start IV fluids on this individual, and it was unsuccessful. Thank goodness she was treated in the hospital, came back to the nursing home, and actually was successfully discharged home with her husband. This patient could have died. So this is a preventable adverse drug event, and I would say potentially it is from the olanzapine, making her confused, and it was very difficult for her to communicate. 79-year-old male is found to be having a seizure by nursing staff on a Sunday afternoon. The on-call provider is called, and an order for lorazepam, 4 milligrams. It's a lot. IM times 1 is given. Several hours later, the resident is unresponsive, and they cannot get a blood pressure because he's so hypotensive. He's transferred to the emergency room. After admission to the hospital, it's determined that the resident was a DNR, comfort measures only, per discussion with the MPOA. So patient should never have been transferred to the hospital. And then the resident is transferred to a hospice facility per the MPOA request. So this is potentially ameliorable. Was a very large dose of lorazepam that was given in the hospital. So potentially this was a preventable or ameliorable. And conversation should have been had with the MPOA probably prior to sending this patient out. Case example number 3, a 55-year-old male complains of worsening chronic back pain. He's receiving hydrocodone, acetaminophen, 7.5 every 4 hours as needed. Nursing contacts his PCP over the phone, and an order is given to stop the hydrocodone and start a fentanyl patch, 50 micrograms. That's a fairly large dose of fentanyl. He continues to complain of pain, and the patch is increased to 75 micrograms 5 days later. A day after the increase in dose, he is found unresponsive and hypotensive, and EMS has to come and administer Narcan to the resident with good results, right? Wonderful that he was saved. This was essentially preventable. Increasing an opioid this rapidly is not at all appropriate. We need to go slow if we're going to increase at all. So there's a lot wrong with this case, and it definitely preventable. Case number 4, 79-year-old female is prescribed a 7-day course of levofloxacin for UTI after UA was ordered for symptoms of nausea, no fever, no leukocytosis, no pain on urination, no abdominal pain. 3 months later, she stands up from her bed and develops acute, severe left lower leg pain. She's sent to the ER and diagnosed with left Achilles tendon rupture, and she's admitted for repair. I've seen this happen with this class of medications, levofloxacin, ciprofloxacin. Achilles tendon rupture is real side effect of these medications. And just because it doesn't happen right after you get the antibiotic doesn't mean it's not going to happen. It can happen months and months later. This is why we have to be really good antibiotic stewards, because we don't want these things to happen to our patients. So this is preventable. Perhaps that patient didn't even need antibiotics. So I want to talk a little bit about cognitive bias in closing us out. So when we make our medical decisions, we have 2 paths to follow. If we're making a decision, we can be very fast, boom. This is when we're driving. Maybe that decision should just, turn left to get home. We know where we're going. We make a lot of our decisions in healthcare this way, knee jerk, fast, which is fine at times. Type 2 is slow and deliberate. This is how we should be making most of our medical decisions. Stop, think, let's see if we're doing the right thing. Type 1 thinking can reduce cognitive load. Like, it's taxing to think about something. It takes energy, but it's biased by our subconscious. If we're hungry, if it's a habitual response, if it's emotional, these things lead to medical errors. That's why we have to be deliberate and thoughtful when we make medical decisions. That's called cognitive bias. This is an error in judgment, and it makes a huge impact in medical decisions. So if we look at cognitive bias and antibiotic prescribing, so say if we have a 75-year-old nursing home resident, she's sent to the ER after a fall, no fracture is found, but she's given a prescription for ciprofloxacin for a UTI after report is called to the ER, and the nurse says that she has foul smelling urine, and it's reported that a UA is highly suggestive. So this doesn't meet criteria for a urinary tract infection, but we have cognitive bias in saying that her urine is foul smelling. This cognitive bias is an example of diagnostic momentum. That's an incorrect suspicion that gathers momentum after it's passed from individual to individual. Like that game of telephone where one person says one thing and then one person says one thing and one person says the one thing. It's wrong. This is not the way medicine should happen, but it's the way medicine does happen. But this is what we can prevent. I say knowledge is power, right? So tools to recognize and overcome cognitive bias: slow down. There's very little that needs to be done at a fast pace, immediately, urgently. There are some things, if a patient is having a cardiac arrest, go fast. But most of the time, we need to slow down. We need to think about what we're doing. We need to deploy metacognition. That means we're thinking about our thinking. So that means if you're saying, well, you have to say, how am I making this decision? Is it an appropriate way to make this decision? Ask your colleagues, talk about things. It's a really great way, to think about medical decisions, and utilize checklists. You can check yourself. Again, double check and triple check yourself. When I was teaching medical students, I told them all the time, triple check, triple check, triple check. Always, always, always. We don't want to harm a patient from a medical error. And seek the input of colleagues. And take a time out. Stop. Say, am I really doing the right thing? I wanted to close out talking about ethnic differences in adverse drug event risk. So clinical trials are just starting in this area, but I think they're very interesting. One clinical trial looked at significant more depression associated with hydrochlorothiazide use, which is for blood pressure, in Black patients as compared to white patients. So something we should be looking out for in our different patient populations. 5 studies have demonstrated significantly increased risk of angioedema with ACE inhibitor use in Black patients. Again, when we're prescribing a medication, then we can offer additional education to our patients. 3 studies showed increased risk of bleeding with thrombolytic therapy in Black patients. So really important to keep in mind that certain individuals are going to have increased risks. So we have to take this into account when we are counseling our patients regarding medications. So take home points. We talked about the several types of adverse drug events and determining type. We can respond appropriately. We can respond appropriately to change our processes so we don't hurt patients. Polypharmacy, more medications a patient receives, the more that they're increased risk for adverse drug events. Health professionals, consumers, and patients. We can all report adverse drug events to MedWatch. Hospital adverse drug events have declined due to increased education and awareness, just like what we're doing here. Adverse drug events remain a problem in long-term care facilities, but individual facilities can take advantage of many opportunities to reduce this risk. There's so many different areas where we can catch adverse drug events. Providers serving the long-term care population, they need to become aware of the unique challenges. We do have unique challenges, but we need to recognize adverse drug events, and we can. Cognitive bias contributes to medical errors, and it's important that we recognize how these cognitive biases are playing out in ourselves. And it is important to have an awareness that some ethnic groups may be susceptible to certain adverse drug events. And so we're aware, then we can provide appropriate medical recommendations and education that is tailored to the individual. Any questions? And I really apologize for dropping out on everybody. Kathy, are there any?
Thought I unmuted myself. Dr. Storm,
Okay.
thank you for that great presentation. So in a moment, we'll begin the Q&A. And if you have a question, please submit it at this time using either the chat or the Q&A tool, or you can raise your hand to ask your question out loud. There is a question in the chat already, so I will read that. It says, when we send a resident to the ER, we always send a current medication list. When the resident is readmitted, they are on medications that we did not have them on. The hospital pulls up med list in their system from the last time the resident was in the hospital, could be over 1+ years ago, and administer those meds, including narcotics, PPIs, psych meds, etc., while in the hospital. All of the medications which the facility and PCP has worked hard on reducing / eliminating the use of those meds. This has been an ongoing issue for years. Should this be reported as a hospital medication error?
So that's a challenging thing. So I always take the stand that I want to do what is best for the patient. I would call the hospital and say, this practice is not working. You do not have the appropriate medication list. I know that at these facilities, when you send a patient to the hospital and you are calling a report to that emergency room nurse, you are sending a packet that includes the patient's current medication list. I would stress to that nurse that you call in the ER, that is the current medication list. Don't pull an old one. You're going to hurt this patient. We're going to cause a medical error. I would stress that because I think that that's a definitive problem and a definitive area that needs to be improved. And I'll say, I have actually called physicians in the ER and said, listen, I don't know what's going on, but this medication list you sent, did you add all these medications? Because it's totally different. And the physician will say, I never got a list. I don't have access to the nursing home's EMR. And so, it gets lost. But I think it can be prevented by really good communication, provider to provider education. And again, I would encourage your medical director or attending physician at your facility to call the ER physician and say, like, what's going on? Something's not right. As far as reporting as a medical error, I mean, you prevented it because you're not giving the patient those medications that they don't receive anymore. So I don't know really if it's an error. Potentially you could call it something that's preventable and give yourself a pat on the back because you prevented it. Sorry, it wasn't a better answer.
Thank you. And we don't have any more questions so far that I can see. So I'm going to run through some quick closing items. And then if there's any more questions, we'll get to it real quick. And then see, Dr. Storm, I thought I sent you that updated slide. I'll have to share it on my screen.
Okay.
Some quick closing items about the CEs. We are missing the link in that slide, so I'll have to share it in my screen. So real quickly, I wanted to remind those who are here today that are part of a long-term care facility that doesn't usually join these webinars. This is a weekly series, and next week we'll be having a discussion on enhanced barrier precautions. So we invite you to join us next week at Wednesday at 2 p.m. if you're interested in more webinars in this series. And if you would like to receive any invitations to our newsletters, you can contact me if you would be interested in being added to our mailing list to receive our weekly newsletter and our webinar recording invitations. My email is ccaudil@qualityinsights.org, and I just dropped my email in the chat. And I'm going to share my screen now real quick. Let's see. Can you see that slide? Here we go. There we go. Okay. And of course, it took over my whole Zoom, so now I can't see the chat. So I'm going to take a moment and I'm going to put some links in the Q&A. All right, so I'm going to drop some of this information in the chat for everybody. Okay, so as we said at the beginning of the webinar, those of you who are interested in, oh wait, I'm sorry, I had just a moment. Something else I needed to say. Okay, so I wanted to say if we did not get to your question today, you can contact Dr. Storm at jstorm@qualityinsights.org. In a moment, I'm going to go over the instructions for those wanting CE credits. If you are not here for CE credits, you can ignore the pop-up window with the SurveyMonkey link that will show up when you close the Zoom. And then you could also, if you get a follow-up email from Zoom with that link, you can ignore that as well. That's just for the people wanting the CE credits. All right. So as I said before, at the beginning of the webinar, those of you who are interested in CE credits will need to complete an evaluation. In order to receive your free nursing CEs or certificate of completion, you will need to score at least an 80% on the post-knowledge check. And once you successfully complete that post-knowledge check, you will be forwarded your certificate. As I mentioned earlier, the email, I will be emailing the recording to everyone and the slides later this week. So if you have a colleague or support staff who would be interested in the webinar or the CEs, you can pass that information on to them. And I will also be posting this on our website, qualityinsights.org/QIN/multimedia later this week. So as you can see here, we have a few ways for you to pull up the link to that post-webinar evaluation and knowledge check. As you see, I have posted the link in the chat. You can also scan it using your phone to scan that QR code there. That's another way to get to it. You can wait till the webinar ends and a pop-up window will show up with the link. And then Zoom will also send an automated email with that link too. So that's a lot of different ways to get it. And if all else fails, you can contact me to get the link at ccaudil@qualityinsights.org. I know we ran a little bit over today, so if you don't have time to take that evaluation right now, you can take it later. I'd like to thank all of you for joining us today. And Dr. Storm, thank you for joining us today. And sorry, this webinar ran a little bit late, but thank you all for sticking it out with us. Hope to see you all back here next week. Thank you.